This editorially independent episode of New Retina Radio is supported by Alimera, a global pharmaceutical company whose mission is to be invaluable to patients, physicians, and partners concerned with retinal health and maintaining better vision longer. Alimera. We see more together.
Welcome to New Approaches to Chronic Postoperative Inflammation, a New Retina Radio miniseries. My name is John Kitchens, and I practice at Retina Associates of Kentucky. On this miniseries, we'll examine management strategies for one of the most confounding and frustrating complications we encounter as retina specialists. I'm talking about postoperative inflammation. On this episode, we will focus on the initial encounter with postoperative inflammation. We'll see how experts in the field examine patients and evaluate patients and what their choices and options are. Luckily, we have two such experts here today. We have Lisa Faia from Associated Retina Consultants in Royal Oak, Michigan. Hey, Lisa.
Hello, thanks for having me.
Thank you. And we have Daniel Kiernan, who is from the Eye Associates in Sarasota, Florida. Hello, Daniel.
Hey, John. Great to be here with my amazing co-host, Lisa.
Fantastic. It's so great to have both of you guys on here. And, you know, this is something that we don't face as commonly in clinic, but it's postoperative inflammation. And we're going to focus on it more in the retina context. So not really post-cataract inflammation, but what I perceive as being kind of one of the more difficult things to treat, and that's the post-vitreoretinal surgery patient with inflammation. Lisa, when do you encounter a patient like this? What's the typical type of surgery? What's the time frame? Does it present like post-op CME from the cataract standpoint?
I mean, from the retina standpoint, it seems a little more insidious. Like it's usually they've had a detachment, they're doing well, they develop the ERM. Oh, okay, let's go back, let's go and peel this. And then we peel it and they're like, you said the distortion was going to be better. And they still like, yeah, it's better, but things are still a little minimized. There's still a distortion. And, that doesn't look like, that picture doesn't look like the back of my other eye. Like, what's going on with this? We've been on drops for so long. It's bothering my eyes. When am I going to get better? That's that kind of thing. And I would say, it's like, they kind of give you those first 2 months as a little leeway. And even when you have to tell them they have the second surgery, they're like, okay, well, you told me this might happen. But at 3 months, they're kind of getting tired of it. And they want something different. And that's very reasonable to me.
And Dan, when you first evaluate these patients, what is a real key thing? OCT, fluorescein angiogram, what are the common ways that you evaluate a patient with this presentation?
Right. Well, obviously they're presenting with usually a symptomatology such as decreased vision or metamorphopsia with distortion. And although exam is very important, I still use fluorescein, especially to establish a baseline and to look for more insidious post-op inflammatory signs like disc and macular leakage. By far and away, OCT is, the gold standard for diagnosing, especially macular edema associated with post-op inflammation. And I use that on every patient, every time it comes into my clinic and every follow-up, no matter what the treatment modality might be.
And so when these patients first present to you, Dan, what is your first steps in therapy for a patient like this?
Well, I do want to quickly review their records and see what kind of surgery they had and when, because if it's more of an acute process, which you more commonly see after cataract surgery in the setting of, say, Irvine gas syndrome, a lot of times topical therapy, even just tincture of time will suffice. But these patients that we're really talking about, Lisa alluded to that, chronic retinal detachment patient who's maybe had one or more surgeries, including prior cataract surgery. They've got this more chronic cystoid changes that they're affecting their macula. They're probably going to be a lot more fluid and a lot harder to treat. So although I oftentimes will say to the patient, let's restart those drops. Do you still have anything left over from months, years ago? I think every patient is more comfortable doing that than rather going straight to something more aggressive like an intravitreal injection, but not always. There's a lot of fluid, and especially if they're being treated for something else, they've already experienced intravitreal injection. I have no qualms against starting them off with an intravitreal steroid.
So Lisa, let me back up just a second though first and say, are there any things intraoperative that we do or could avoid that could reduce the chances that these patients develop postoperative cystoid macular edema?
I mean, the biggest thing is to assess systemically their comorbidities, right? How is their blood pressure doing? Are they diabetic? How are their blood sugars doing? My favorite is when I tell a patient, so is your blood pressure okay? Your blood sugar? Oh, it's fine. When's the last time you saw your primary care doctor? Oh, it was about 5 years ago. Well, I guess if you don't know, you don't get the diagnosis. So sometimes just asking those simple questions, I tell my fellows that they say it's fine, but if they haven't been there for a while, that's kind of the thing. So interoperatively, I like to know, or beforehand, actually, what's going on with that. And I'll look and I'll see, okay, there's a lot of droplet hemorrhages and they say everything's fine. So those kind of things, I don't know how much I would change. Like if you have to peel a membrane, you have to peel a membrane, and that's just the way it is. I don't think peeling less extensively will give you less inflammation. But for me personally, if it seems like, again, their postoperative course has been more complicated, I'm more likely to even possibly do an injection or a subtenon's injection in those patients, or maybe even an anti-VEGF if they're like, yeah, my blood sugars have been bad, but I can't deal with this eyeball anymore. So from an intraocular standpoint, I know about not doing things, but definitely things that I might supplement ahead of time or have in my brain before I even take the patient to the OR.
I can think of one situation, and you guys might encounter this. Hopefully you don't, but it's when I've had subretinal PFO. That seems to be something that is just so seemingly pro-inflammatory that even once you get that subretinal PFO out, it seems like those patients develop a whopping case of CME that is really recalcitrant to just our standard treatments. Do you ever have any experience with that? And if so, what are your keys?
Well, the subretinal PFO, I think we've all had to deal with at some point in our careers. And fortunately, I haven't had that in many years, other than very small bubbles that were non-central part of the retina. But I agree, any sort of remnant like that left in the eye can cause somebody to be predisposed to postoperative inflammation, CME. One other thing we can consider, and I've used before, is surgical adjuvants such as intracameral dexamethasone or DexEQ. Unfortunately, that's lost its pass-through status, so it's been kind of sidelined for the moment. But I do still use intracanalicular dexamethasone or Dextenza. I've used that today. What's nice about that is it actually provides a continuous dose steroid anti-inflammatory effect over the next few weeks after surgery, irregardless of whether the patient's prescribed or is compliant with topical anti-inflammatories. So I think those may predispose the patient to have less likely a chance of getting CME, although that's still somewhat debatable. I've presented a couple podium presentations on that, but I think we want to make sure our patients are adequately treated in the immediate acute postoperative period with sufficient anti-inflammatory treatment, or if they're undertreated, they're probably going to be more likely to get long-term chronic postoperative inflammation, CME.
So let me just ask you here, Dan, what is your postoperative routine as far as a normal membrane peel, let's say, or a diabetic tractional retinal detachment? How do you manage those patients just straight out of the gate?
So if they have the appropriate insurance, as I did today, I did 4 cases, 3 out of 4 post-op patients received intracanalicular Dextenza at the end of the case. Those patients will be seen tomorrow, and they will get their topical antibiotic for 4 times a day for a week. And usually I do topical steroids such as the Durazol generic equivalent 4 times a day for 2 weeks, and then twice a day for 2 weeks. If I give a patient Dextenza, I'll give them basically a topical antibiotic and a topical steroid 4 times a day for 1 week, and then stop everything. And I've had good results with the Dextenza. And I had one patient I did vitrectomy for floaters, one patient who I did a membrane peel on, and one patient who had an extremely complex retinal detachment that I used PFO and gas and membrane peels at the end. And I used Dextenza for all those patients, and I've had great results with all of them. Sometimes you have to up the steroid in the more complicated cases. This patient who had a recurrent detachments had maybe 4 or 5 surgeries at this point. She's more likely to be, have more inflammation. I don't hesitate to up the topical steroid. I still give topical steroids to everybody, regardless of the Dextenza. I just feel like it's better for the patient to have it and maybe not have immediate pain or more inflammation, especially if I'm having another colleague see the patient day one. They don't necessarily know if it's a lack of communication that the Dextenza went in. It's hard to see. There might be too many questions, and I don't want to overwhelm anybody, whether it be the patient or my doctor is helping me out.
Wow, really aggressive with the steroids, Dan. Do you operate at a surgery center or in a hospital?
I operate at 3 different surgery centers.
And with the Dextenza being placed at the time of surgery, is that considered a pass-through, or how is that?
It still has the appropriate status where it's reimbursed separately because it was shown in the clinical trials to reduce pain, whereas unfortunately DEXYCU did not test for that. So the Dextenza folks at Ocular Therapeutics were very, very smart and were able, because of the whole opioid crisis, were to say, hey, pain management is key. We should be allowed to keep this pass-through status. And sure enough, the FDA approved that, whereas DEXYCU lost it because they couldn't say that about their pain reduction. So I think that's really important to bear in mind, is pain and signs and symptoms of inflammation that you're treating.
And Lisa, for you, hospital or surgery center at Beaumont?
So most of the time it's hospital. I tend to get the more complex diabetics and detachments and stuff like that. So they require longer, or they're just not well enough to be done in a surgical center. I have that option, which sometimes I'll do my floaterectomies there, but for the most part, just because of what I like to do, I usually end up in the hospital.
And what do you use for your post-operative management, just in a routine case?
Yeah, so honestly, for me, routine, I just want to make it as easy as possible. I like the Dextenza. I didn't ever even thought of that as an option. I just was like, I kind of just want to get my stuff done. And, sometimes after a long case, you're like, okay, let's move on here. But I do gentamicin for a week and atropine, once a day for a week, just to kind of prevent any sneaky eye, because I always worry about that. And I just do prednisolone acetate. Like, it's easy to get. Sometimes we had a shortage where we couldn't get the Durezol, generic for a while. And then, sometimes with the gas bubble, the pressure goes up. I'm like, I don't want to deal with it. I don't need to see him more often. I'm going to see in the day, I'm going to see in a week. And I do keep people on prednisolone for a whole month. About after a week, I go down to 3 times a day, because I think it's so disheartening, not only for me, but for the patient to like, oh my gosh, I thought it was getting better. And you're showing me this picture. I stopped the drops 3 weeks ago, and now I feel like I'm just back to square one. And so I just honestly don't want to deal with that. I know it sounds selfish. It's also best for the patient, knowing the inflammatory response is 4 to 6 weeks is when it's really kind of revs up there. So stopping it at like 3 weeks, to me, I'm like, the immune system hasn't even had a chance to respond to healing. And 4 to 6 weeks, that's when the deadly stuff is going to start. So I keep them on for a longer period of time and tell them it's worthwhile, knowing that they're probably only doing it twice a day, even though I want it to be 3 times a day. But it works out really well. And I hate having to restart drops. I'd rather just keep it longer from right out of the gate and then kind of go from there.
And before we go to break, I'll blow your minds here. We're basically your kind of bread and butter retina practice here in Lexington, Kentucky, in a surgery center. We only use antibiotic ointment twice a day for a week. No steroids at all. And we actually looked and presented a couple of years ago an ARVO poster looking at rates of CME before and after we had done that. And it was fairly equivalent as far as that goes, between using atropine and steroid drops and antibiotic ointment versus just antibiotic ointment twice a day for a week. And seemingly that's got the job done for most of our patients. But we do run into some of those patients that have recalcitrant, tougher to treat CME after surgery. And we will get to that right after this break, learning a lot of stuff from Lisa and Dan. Stay with us after this break, and we will come back and talk about that patient that comes back with worsening edema that we need to take it to the next level.
This editorially independent episode of New Retina Radio is supported by Alimera, a global pharmaceutical company whose mission is to be invaluable to patients, physicians, and partners concerned with retinal health and maintaining better vision longer. Alimera. We see more together.
Welcome back to New Approaches to Chronic Postoperative Inflammation, a New Retina Radio miniseries. Now we're going to examine kind of that classic patient that I think we've all faced in the retina world, that patient that has come in after surgery, maybe 3-4 months later, and they've developed this macular edema. And this is tougher to treat macular edema than your typical postoperative cataract macular edema. Lisa, let's say you've tried drops and the patient's just not, responding. What do you go to next? What's your thought process?
So, if I feel like it's more anterior source, then I will probably go to just a old-fashioned subtenon's Kenalog injection, knowing that make sure the nerve is okay, and if there's a spike, because it's not as controllable, that might be an issue. Or Xipere is nice. It's a little bit, there is definitely a learning curve to it. It's not like subtenons, which we all kind of, it's like lickety split. or intravitreal injections. So there's a little learning curve to it. But when it comes to patients who have the CME, and if it seems more anterior, the source, I got to tell you, I've been pretty impressed with it. And again, the pressure is much more manageable, much more predictable is, I guess, the best word for it from that aspect. If it seems like it's a little more from a posterior source, I got to tell you, I am happy to use Ozurdex or Utique. I'll start with an Ozurdex, and if it seems like they need one or two, I'm talking to them about Utique. And I know it's like, well, why, if it's only been 3 months, why are you already thinking that? It's like, well, because this person's already going to be upset. And you need to have that next thought in your mind, not only because you want to make sure you can offer to the patient, but the fact that I had to already think, okay, I might be thinking Utique. I'm going to have you fill out this paperwork now because it might take 4 to 6 weeks for me to get approval. And if I get approval, we got to know what kind of assistance you need. And so I always kind of have that in mind, not only for patient care, but unfortunately, it's a game we have to play to get things on board with the insurance.
Lisa, it was really, this is really when the switch flipped for me as far as long-term therapies like a Utique, was realizing that this postoperative CME is at its essence, an inflammatory condition. Can you talk a little bit about that?
Yeah, I mean, basically, some of my partners have asked, well, how do you justify using an Ozurdex, because the label isn't for post-op CME. But I got to tell you, if there is edema afterwards, whether you have an FA or not, it's an inflammatory source. And if you feel more comfortable, sometimes what I'll do is I'll do a focused workup. I don't want to waste money or patient resources. I don't want to do that aspect. But if it seemed like it's persistent and then maybe surgery was I thought it was a little more routine than I thought, but they still have this persistent, I don't think it's a bad idea to do a quick focus workup. Hey, rashes, joint issues, it doesn't take much longer. Get that stuff going. And then again, for me, I do think it is justifiable saying as a posterior uveitis. And everyone hates that word uveitis. Oh my gosh, holy crap, Ola, send it out. But no, it doesn't have to be like that. It just, you'll do the workup, make sure you're really not missing anything else, and then proceed with an Ozurdex from there. I just think there was a nice study just for anterior uveitis, which showed that patients who only risk factor was being African-American, they would be on drops for a year. And after drops for a year, they all did very well. And it's just, sometimes we think that if it's not gone in 3 months, that, well, why would we wait longer? It really is, the immune system is very annoying, quick to react, slow to calm down. So I do agree that we need to be more proactive with these long-term therapies.
And Dan, we had talked at break about Xipere, the suprachoroidal triamcinolone injection, very novel delivery technique. What's been your experience with Xipere in patients with postoperative CME?
I find it actually pretty helpful for patients, and it's kind of become my go-to for those patients who also have secondary glaucoma that I feel is higher risk. A lot of these patients, it's a rock and a hard place, and they're often being co-managed by one of my glaucoma colleagues. I've already received a tube or a shunt, or they're planning to do such, or even a diode. And so you really have to take that into account when you're managing the risk to benefits. Nevertheless, I feel that the Xipere safety data, as reported in Peachtree and the subsequent Magnolia trials, showed that it was less likely compared to standard of care to increase the intraocular pressure more so than, say, the other options. In the Huron trial with Ozurdex, it was about 30 to 35% of patients usually noticed an IOP spike around week 5 to 6. With Utique, it was a little less than that. Fluocinolone 0.18 trials, it was still more than the Xipere. It's not directly comparable, but I think those 3 options have been kind of my go-to. Those are the 3 main arrows in my quiver of anti-inflammatory steroids: Ozurdex, Utique, and Xipere. In my training, and I think Lisa and I are in the same class, actually. We had peribulbar subtenon's Kenalog, and that's still great. Some people still use it. I rarely use it. I just feel like there's a lot of, not necessarily challenges. I mean, you could risk low perforation, nobody likes that. But the main thing is it's just unpredictable. The dose is a little unpredictable. You still get the side effects of intraocular pressure rise. You can't really control it. You can't take it out if the intraocular pressure goes up. And so, the black box warning for that is now effectively eliminated intravitreal non-preserved preservative, a positive preservative Kenalog from, are as an option because of this pseudo-endophthalmitis. And so we're kind of happy to receive Alcon's Triessence back in, what was it, 2006. And now there's this national shortage that doesn't look like it's ever going away. And I haven't used Triessence in almost 2 years now. And so nobody in my practice has been able to get it. And so really, I think that those three options I told you about, the Ozurdex, the Utique, and the Xipere, are really going to be the kind of on-label options that we go to most for our kind of chronic postoperative inflammation, especially when it's associated with macular edema.
And Dan, how do you tier those?
So a lot of the time we can't get around this issue of what the type of insurance the patient has. Unfortunately, all of those products, because they're on label for the postoperative, or I should say posterior uveitis or posterior cyclitis, there's a few different terminologies that are used, and many times you have to code it as cystoid macular edema as number one, and then posterior cyclitis is number two. I have the patients fill out those patient assistance programs, sometimes all three companies worth, and I submit them all. And many times I'll have something in mind depending on their relative risk factors, like more at risk for glaucoma. Okay, let's try Xipere. More of a go-to, let's try this, like first line, let's try Ozurdex. If I've already had an Ozurdex or two and it's still recurring, especially before like the 90-day mark, I'm thinking Utique. And I've had great experience with all those products. And I think Xipere I have the most insurance difficulty with at the moment. It's the newest product, so no surprise. But I think we all have very effective on-label treatment options. And hopefully, although relatively expensive per unit compared to some of our other intravitreal treatments for, say, other diseases like anti-VEGF, I think if you look at it from a time standpoint, it's still relatively inexpensive. And I have a lot of patients who are willing to pay out of pocket when need be, depending on their insurance, copays and whatnot, to get rid of this situation, because it's like night and day after you inject an intravitreal steroid compared to what they might have been on with drops for a long period of time.
Yeah, you're 100% right. We have options. And I think the key is realizing that this is a post-operative inflammatory, a uveitic condition. Lisa, you brought up something very specific at the break, and that was secondary IOLs. Is there anything different we need to consider in patients like that?
We were kind of talking about that before, the cataract surgery that already went bad and there's no capsular support. So yes, that's my thing. Mostly sclerofixated lenses. I really don't like to touch the iris if I don't have to. But those are not candidates for any kind of implant. So unless you're going to do a Retisert on them, which is surgically, sewn in, Utique and Ozurdex, you risk migration. And it's on the box that says if the posterior capsule is violated, except for YAG, that this is not indicated for those patients. And those are the patients that need it. So I know CC Lynn, actually, who's here at Kreisky down the street, has done one or two where he has actually sewn in a Utique. And I thought that was really interesting what he had done. I think one of them, actually, he did it and it migrated. It was not, Zaniol sometimes do that. And he didn't want to waste the $9,000. So he sewed it in, and he has actually presented that, which is wonderful. But otherwise, again, without that capsule, Utique and Ozurdex, you're not going to risk then the cornea going bad. So that's why Xipere was a really good choice for me from that aspect, because of course there's always an issue with pressures after those. So I agree with Dan that unpredictability of the subtenons injection, even though that's what it used to be, I don't like that when you have something that's a little more reliable when it comes to whether you're going to have a pressure issue. So those are patients that, unfortunately, Xipere is really the best option, because again, you worry about migration.
Fantastic. One pearl you would give to anyone who's struggling to manage these patients, Lisa?
One pearl to give. I guess it's this hard part. It's easy for us to say, but be persistent. But at the same time, be willing to do the next step. Don't, if you're like, oh, this should have worked and it didn't. Okay, it didn't. Go the next step. You need something longer. Don't perseverate on it, because you're going to get annoyed and the patient's going to annoy. So just be persistent and be willing to move on.
And Dan?
Just I guess sort of a tangent from that is postoperative inflammation is posterior uveitis, and it's often associated with cystoid macular edema. And whether you term it as chronic postoperative cystoid macular edema or the kind of classic following cataract surgery Irvine gas, it's all an pro-inflammatory disease that's very effectively treated by steroids. And so you can't just keep beating around the bush with topicals. If it's not working, it's obvious. Sure, you could refer them out, but this is
I as a uveitis specialist who sometimes gets these patients, people are like, well, aren't you okay that they're easy? I'm like, no, they're so high maintenance because they have multifocal lenses and they have a little edema. I'm like, that's it. You know what? Hold still. We're putting the Zy-Pure in. If someone else can just deal with it, and I'm happy to deal with my 15 serpiginous birdshot patients. I'm okay with that. Because they are grateful. These high maintenance one, I'm like, gosh, can someone just put an injection in here? I don't need to deal with this.
Yeah, I'll tell you, our two most valuable resources is a retina specialist, neuro-ophthalmology, and uveitis specialist. Like don't send them anything that is not actually really serious stuff. Listen, Lisa, Dan, I want to thank you for joining me on the new Retina Radio miniseries, New Approaches to Chronic Postoperative Inflammation. You've been educational and entertaining. We have 2 more episodes coming out, so stay subscribed to New Retina Radio so these episodes automatically appear in your podcast feed. For now, my name is John Kitchens. Thanks for joining us.